So the topic given to me was risk assessment in patients with diabetes, whether it should be a stress test or coronary CT angiogram. The or nothing is something I've added myself because that always reveals an alternative. So cardiovascular disease in diabetes is almost a foregone conclusion. It's a very, very atherogenic condition. This table here shows you the data from almost 8.49 million years of follow-up, that almost 2 times risk of all kinds of different vascular diseases increased in patients with diabetes. And this risk starts from somewhere between 5 to 6 millimoles, that is about 100 milligrams per deciliter of glucose. And it is a linear graph with increasing glucose, the number of cardiovascular events keep on increasing. So as severity of the diabetes increases, the vascular events also increase. Now, this is something which I think Dr. Anup also alluded to in this previous thing, that somehow we are genetically programmed to develop many more cardiometabolic complications. Probably some kind of fetal, intrauterine programming also, some early childhood problems, whatever. The thing I'm trying to make a point here is that while this is the relation in the Caucasian population, it is quite possible, and it is true, that Indians are very sensitive to the complications because of glucose. So, for the same amount of glucose, we could actually be having much more vascular events. It is also possible that this slope of the graph is actually much more steeper in Indians, and hence it has been found that the excessive mortality and morbidity because of diabetes in Indians, a lot of it can actually be contributed to enhanced sensitivity to diabetes in Indians. So we know that diabetes increases both atherosclerotic burden as well as coronary ischemia. How much? Well, even in asymptomatic people, about 25% have been found to have silent ischemia. And this has connotations because over 5 years of follow-up in this study with SPECT, which is fairly accurate for detecting ischemia, almost double amount of major adverse cardiac events happened as compared to people who had no ischemia on the SPECT. And similarly also amounts to actual anatomical level of atherosclerosis. So this is a large study of almost 30,000 people from Sweden, a community-based study in which they have done CT scan for everybody. And then they have kind of seen the distribution of the coronary plaques in patients who were euglycemic, who have pre-diabetes, and who have diabetes. And I would like you to focus on this part of the coronary tree here. This is the so-called killer area because plaques in this area of left main, LAD, and RCA are actually the ones which cause sudden death, MI, etc. And you can see that the number of any plaque or significant plaques is huge as compared to the normoglycemics. And in the pre-diabetes part, it is almost intermediate between the normal and the established diabetics. And then this has also been seen in the same study with the coronary calcium score, where diabetics, even in women, had much more higher coronary calcium score, and the risk and the prevalence increased as the diabetes severity increased. And this study is the same thing as the previous one, except it's in US. And what I want you to focus is these 4 arrows here. So even if people have less CVD risk as per the normal calculators, US or UK or Europe, even in those, so people at low risk clinically, even those have almost 45% of them have coronary plaques. So people keep on asking me that why do people suddenly develop events? This is the answer. Even if you don't have high vascular disease, even then in diabetes you are going to have plaques, and this is also true for calcium score. So even with a calcium score of 0, you will still have coronary plaques if you have diabetes. And what does this convert to? This converts into increased all-cause mortality because of increased MI and increased sudden cardiac death. So in this study where, again CT-based study over 5 years, they saw that people with diabetes who did not have plaques in their coronary trees actually had the same mortality as people with no diabetes. But as the number number of plaques increased, the mortality hazard ratio kept on increasing. So it's very clear that coronary plaques in diabetes are a bad thing, and CT scan is a good way of confirming that. So then this begs the question that every diabetic, because there is so much of atherosclerosis, there is so much of ischemia, so all of them should undergo routine ischemia testing or screening for CAD, right? So this study exactly looked at that. So people with ischemia, it followed them up with good medical therapy. And what it found was interesting, that just with medical management, a lot of this ischemia was able to be reversed. Nothing else was needed. And then this was a large trial reported in JAMA in 2014. So remember, as we are progressing in the different studies I have showed you, the medical management of CAD and diabetes is increasing. There are more and more people being given high quality drugs like statins and probably newer anti-diabetic drugs, more intensive LDL cholesterol lowering, more aspirin, like that. So this study actually looked at asymptomatic patients with diabetes and randomized them to care based on CT scan findings or the standard usual care. And you'll be surprised that nothing came out of it. So patients who are given standard usual care as compared to patients asymptomatic patients who are subjected to a CT scan and then the care is decided. Well, in the long term, it doesn't matter. They all were having the same amount of events. This was a little bit surprising at that point. And then, if we combine all these studies, whether functional testing or by CT scan, we look at enhanced coronary risk in patients with diabetes and subject them to management based on that decision, again, the results are actually quite bad. There is no change whether you subject them to these tests or not. So the thing now is that, should individuals with diabetes be subjected to these tests at all if they are asymptomatic? Well, the answer is no. And I will show you the further evidence for this also. So people who are asymptomatic actually do not need any other kind of, but then we have to be sure that they are asymptomatic, and that involves a little bit of a probing history, because Indians are very, very reticent when it comes to history, being given history about their discomfort on exertion. And if you have some kind of a chest discomfort equivalent, and this is a big cave, rather, I would say, in diabetes. If you ask these people, they give all sorts of symptoms which actually turn out to be angina. It could be just discomfort, it could be SAR adaptations, it could be belching, it could be epigastric discomfort, it could be dyspnea, it could be pain in the back. So all these are angina equivalents if it comes to diabetes. And yes, in them, probably it does matter. Depends on what we want out of this screening. You want to prognosticate a patient? Yes, it does help. You want to up-titrate the medical management? It does help. Revascularize them? Well, mostly no. It doesn't help. So this is one large study for, again, in the last decade, 2 or 3 huge studies were done which looked at patients with stable coronary syndrome. That's the term used now for chronic coronary artery disease. So these patients have some kind of coronary artery disease. They have some symptoms. They could be atypical chest pain or typical chest pain. And then these people were randomized to receive either a CT scan based care or a functional test. This was done in US, where the functional test mostly done is SPECT, which is what we call a stress thallium or stress technetium in India. So this was the population, almost 9,000 people. Chest pain typical was present in 15, atypical in 77. This is a usual chest pain distribution amongst diabetics. But the cardiac risk was huge. It was about 19% risk of having events over 10 years, which is big risk. And what they found was that in diabetics, there was a significant difference in non-fatal MI and death as a composite endpoint. While patients who did not have diabetes, there was no point of doing a CTCA for guiding your treatment. And then this meta-analysis also came to the same conclusion that if you do a routine CT scan in patients with and without diabetes, you tend to reduce non-fatal MI, but death is not affected. And then this large registry, which was a community-based registry from Denmark, again showed the same thing, that myocardial infarctions are reduced by routinely screening patients with stable chest pain. but the other all-cause mortality is not reduced. So then why is this happening? How come a simple test is causing further downstream effects in terms of reducing MI? And so again, this is a little bit of a complicated slide, but I just want you to focus on this group here. So let's say somebody who doesn't have any chest pain, you just routinely screen him with a CT scan. And this person, since because his pain is not angina, probably at this point most of the people will stop and that will be it. But actually even in this, a lot of them do have coronary plaques. So if you give them treatment for those coronary plaques, definitely they would have reduction of MI in a later, 3 or 4 or 5 years down the line. And same thing holds true for possible angina. Somebody who comes to you with possible chest pain, you put him on a treadmill, it comes negative. Probably you send him back home saying nothing is required. But if you do a CT scan, then the chances are there's a 2/3 chance at least that he would actually have something, some stenosis seen, and that would actually force you to write some statin, maybe aspirin, maybe ask him to control his LDL and maybe reduce his weight. So like that, and this is one postulated why a CT scan in these people who are a little bit higher risk diabetics helps as compared to a simple TMT or a stress thallium. So does it actually convert into some substantial changes in the treatment? So I will now take you through a very, very pivotal trial which happened 3 or 4 years back, which was called the ischemia study. This is a landmark study which had about 9,000-10,000 patients, international study, including in India. About half of the patients were actually diabetics. So this particular study is actually the portion only related to diabetics. So pretty much advanced diabetes, 33% were on insulin, 32% had history of coronary heart disease, which was significant. They all had severe ischemia on stress testing. 88% had moderate to severe. But angina was less. So there is this dichotomy between angina and ischemia, which we still don't fully understand. And then, they had severe disease. 80% had multivessel disease on CT scan. All of them were mandated to undergo CT scan. And then, there was left main disease in few of them. What they found was that presence of diabetes obviously increased the number of vascular events, and this kept on increasing from no diabetes to non-insulin treated to insulin treated. But what was strange was that routinely offering revascularization by CABG or PCI to these patients with diabetes actually did not make any difference. They still had the same outcomes as people who were not revascularized, and this was quite surprising, but had been reported before. In the same vein, I would now take you to another interesting sub-study from this same study, which shows the impact of revascularization based on the underlying baseline ischemia. So if somebody has mild ischemia, moderate or severe ischemia, there was no difference in the outcome. But if you look at the extent of atherosclerosis, so the difference between ischemia and atherosclerosis in this context is very simple. Ischemia is something which happens to our coronary circulation when there is a flow-limiting stenosis. So that causes symptoms and ischemia because there is acid depression, But you can have extensive atherosclerosis without having ischemia. So if you have 10-30% plaques, that is having far more connotations as compared to 2 plaques which are say 60 or 70% in terms of MI and sudden death. So extent of atherosclerosis is far more important predictor of vascular events, heart events, as compared to ischemia. And this has again been shown in another subset of patients who had diabetes, who have undergone a PCI. You decide to treat them further on depending on a stress test, doesn't make a difference. You may or may not do a test, it will not change their outcome. So where do we go from here? In asymptomatic patients, personalized medicine is the answer now. Something like this very complicated score which has been developed and reported this year from Europe, fairly large number of population. We don't have score for Indians, but I guess we would be fitting somewhere here in very high risk zone. So once you have this kind of a picture, then you can see very high risk, moderate to low risk. I guess most of the Indians by default are somewhere in this region. And because of that, since you offer them statins and good LDL control, and some of them you offer aspirin, Hence, for asymptomatic patients, it does not make any sense to subject them to any kind of non-invasive screening test as a routine test when they have no symptoms. What about symptoms? If they have symptoms, and this is the American College of Cardiology guidance, if they have low risk by something like a similar chart which I showed you, they need no testing. If they have intermediate risk, then obviously it gives equal weightage to both testing and functional testing. But the European guidelines have slightly stratified it better. So if you have low likelihood, so if you have no ischemia or let's say very atypical, very shady symptoms, and then probably a CT angio is a better way to stratify them. If somebody has severe angina, there is no point doing a CT scan because they definitely are going to have coronary artery disease. And this is one simple, schema to show how it can impact the treatment, and this we have already discussed. So, is there no role of stress testing anymore? Well, not so. As I mentioned, again for ischemia, it does help. Several women have microvascular angina. This will be showing as a lot of them may have no CT scan findings, but they do have angina because of this that needs a treatment. And then a CTCA is not possible in about 10 to 15% of patients because of several reasons. And hence, in ideal circumstances, probably if money was not an issue, then appropriate people should get both imaging and functional stress testing. So to wrap it up, in absence of informed local evidence, given our enhanced glucose sensitivity of the South Asians, we assume higher than usual cardiovascular risk for diabetes in Indians and treat it as per that. So I think that pretty much means, although for example, in the European guidelines they say above the age of 40 everybody should get statins if they have diabetes, I think that age should be lowered as far as Indians is concerned. In truly asymptomatic individuals, cardiovascular screening beyond the usual clinical assessment is actually not required. Stress testing is not useful in asymptomatic or doubtful symptom individuals and does not translate into meaningful changes in management. And a CT scan should be used to enforce risk-appropriate medical therapy, aggressive medical therapy in individuals at a so-called low intermediate cardiovascular risk. So patients, for example, some post-menopausal or just about a woman of 50 years who's having some kind of a chest pain which is not exertional, who's diabetic but doesn't have any smoking or in the family history would be fitting somewhere here. So here I think CTCA has a definite role because it kind of gives you an idea of the disease burden that this person has and what kind of prognosis and management you can offer in terms of medical therapy. Thank you so much for your patient listening.